Hello. Thank you very much. It's really, can you hear me?
Yeah.
Okay. It's a tremendous honor to be here. I'm really humbled by the invitation. I want to thank the, oh, my thank you slide is off. I apologize. So I do want to thank the New South Wales Mental Health Commission, and also this trip has been sponsored by the International Initiative for Mental Health Leadership, and I want to thank them as well. So I'm going to talk tonight about need adapted treatment, open dialogue. I'll explain a little bit about that, and then come to, in the end, how psychiatry fits into that and explain this concept of what I'm calling slow psychiatry. But what I'm going to be talking about is about the importance of context, and I thought I would start by explaining a little bit more about me. Thank you. Okay, great. Thanks, Scott. And thank my husband for editing my slides and helping me out and being a great partner for this amazing adventure we've had in your remarkable country. So I do come from the United States, and that little state in red is Vermont, which is where I'm from. So we're up near the border of Canada. You know, when you said Madonna, I first heard Donald, and that name has been very prominent. And I was getting nervous, but because some people in Vermont think that if the election goes in one way, we might just pull that border down from Canada. Not that they want us, but anyway. And then this is just a picture of Vermont, and I just wanted to point it out because you can see that large lake, which is going to figure prominently in another picture. So I'm from Burlington, which is in the northwestern part of the state. The closest city to where I live is Montreal, actually. And you heard about the Howard Center. Again, just to give you some context, Vermont only has a population of 650,000. The county that I serve, my agency serves, is 120,000. We're a fairly large organization. We serve children, adults, people with developmental disabilities, people with substance abuse and mental health problems. We have crisis services, we have residential programs. The program where I've done my clinical work for my career is called the Community Support Program, and that's a program that is designed to treat people who in another era would have more likely been institutionalized. So people who've experienced psychosis, some more extreme states. But our mission is to help people live a full life in the community. And that's been my interest. Now, this is my front yard, kind of this time of year. This is actually from last year, because this winter was relatively mild. So it's a little different. And then this is that lake that I showed you. Those are my two dogs walking on water. The lake occasionally freezes over. But this is when you would want to come visit. It's the summertime. I think the winter might be a bit of a shock. So you can see it's a very beautiful place. Now, I started out, and I'm not embarrassed to say how long ago it was. I went to college in the 70s, so it's been a long career. And I started out being very interested in science. And then I went to medical school, and in medical school I got very interested in psychoanalysis, and that was why I became a psychiatrist. But I became disenchanted with that for reasons I'm not going to go into, and I was at a crossroads of what to do, and I just had always found people who are experienced what I, as a doctor, label psychosis, extreme states, was what drew me in, and it still does. I just find it so fascinating. But that led me in that era, so this is now the early 80s, to be now defined, or as late 80s, as what some people call biological psychiatrists. These terms never really sat well with me, but so I've had this kind of back and forth in my life. So that's when I went and started working at the clinic where I work. This is now the early 90s, with a focus on being the doctor in the clinic, treating people with psychosis, working with a larger team, and helping people to live in the community. But I would have been considered a biological psychiatrist. But what happened next in the 90s is that I became really disgusted with the influence of pharmaceutical companies on the practice of psychiatry and medicine in general. I thought drugs were being overly promoted and distorted. Their efficacy was distorted. I think their limitations being downplayed, and that had a huge impact on me, and I was quite angry, and it sort of generated my looking in other areas, sort of taking a critical view of the field. I would say, and I'll come back to this, I entered psychiatry when the modern Diagnostic and Statistical Manual, that's the manual we use in the United States that's published by the American Psychiatric Association, the DSM. I think it's traveled worldwide, but the modern version came out just as I was starting my training in psychiatry, and I've always had some skepticism about that. I think that it quickly became reified in a way that I never felt comfortable with. But I still, in my clinical work, thought that for psychosis that antipsychotic drugs were essential. They weren't everything that people need, but they were essential to care. And then about 4 years ago, I picked up this book by a journalist, Robert Whitaker, called Anatomy of an Epidemic, and that's where I blog on his website. And in that book, he raised another concern about these drugs, which is that their long-term use may be associated with a worse rather than a better outcome. And that was a new idea to me. I thought the book was so well read, I couldn't sort of take it as true on face value, but I thought it was so well written, that it led me to go back and sort of read the literature myself and come up with my own opinion about this. And I think that I've come to the conclusion that I think this carries much weight. So this led to a crisis for me, and because I thought, up until then, that my job was to convince people to stay on their medications. That's what I often was spending my time doing. So the question is, if I was supposed to back off from these medicines, or it was in people's interest, what then should I do? And that led me to learn about need-adapted approaches. So that's kind of the story, and really, I'm just an ordinary doctor working in a clinic, and it's still kind of mind-boggling to me that I'm here literally on the other side of the earth. My husband figured out that if we dug a hole, when you're a child and you dig a hole through the earth, and we always thought we'd come out in China, but it turns out we'd come out in Perth, Australia. So it's amazing, and I am quite humbled, but it's been, I think, because I've chosen to publicly talk about the turmoil that I've had and the way that I've tried to resolve it in the work that I do, that I've ended up getting to meet people like you and be here. And hopefully we'll have some chance for conversation before the evening's over. So open dialogue is a type of need-adapted approach that I'm going to explain a little bit and then come back to how I see psychiatry fitting into that. And that's this idea of slow psychiatry. That's where I'm going to be heading tonight. So why do we care? Well, the big reason is that they've published studies. I mean, this is how I was introduced to the idea. And in contrast to how I was trained, which is that medications, antipsychotic drugs were essential in the treatment of psychosis, and really since about the early 90s, it's been a prevailing belief in the United States that they should be started as soon as possible, and then continued indefinitely. In northern Finland, where they use this work, and I'll explain why. They really don't believe that. They think that they can begin a different kind of way of meeting with people and hold off on the drugs, and so they've been doing this for about over 25 years, since about the 80s. Late 80s is when they started it, and they've published their outcome data. They're not randomized controlled trials, they're naturalistic studies, because if you go to this region of Finland where they do this, this is the only way they work. So they've compared their outcomes to people in other regions, and this slide compares them to a group in Stockholm. And you can see here only 30% of people in their groups are ever exposed to these drugs. Only 17% are on them at the 5 years. These are a group of people with first episode psychosis. But on disability at 5 years, only 19%. You can see the differences in the Stockholm group, and that would be very similar to what we would see in the United States. So these are almost too good to believe. It's hard to really imagine it, but that got my attention, a lot of other people's attention, and there's now, and I'll talk about it, a lot of interest and activity in trying to see if this can be brought to other places and replicated. So what is this all about, need-adapted treatment? And I'm using that term as opposed to open dialogue because it describes a kind of broader group of approaches. They're all kind of related and interrelated, but I think there's wonderful work being done in Finland where this was developed, but also really wonderful work being done in other places, and I want to acknowledge all of that. So in Finland, during their wave of deinstitutionalization in the 1980s, there was a group in northern Finland under the direction, well, one psychiatrist that, whose book I've read, it's very good, Jyri Alonen, and his colleagues, they were trying to figure out how to help people to leave the hospital. And what Dr. Alonen writes in his book describing the development of this is that he acknowledged that there were a lot of different paradigms to understand psychosis at this time. This is the 80s. So there was some sort of biological ideas at that time. There was a notion that dopamine, maybe excess dopamine in the brain of people contributed to psychosis. This was based on what we knew about what these drugs do. But also there's psychoanalytic ideas, there were family systems ideas, and all of these ideas contributed in some way. All of them seemed to be helpful for some people, maybe not others. And so what they decided is that rather than go in and say to people, okay, this is what's wrong with you, and this is the treatment we're going to give you, what they decided is that they would meet with people and their families and talk together about these different ways of helping and see if they could come together to decide what would make sense for each person. And that's this concept of need adapted, that people are different and people may need different ways of being helped. And so that's how it developed. And what happened is, so they met with them early, they brought people to the hospitals, had these meetings, and they found that for many people, just these ways of meeting seemed to resolve the crisis. Some people got better just from the process of having this meeting. And that was kind of the core basis of the work that they're doing. So they developed this idea of need-adapted treatment, and they decided, it was the late 80s, to do a big study in Finland where they compared this work in 6 different regions. And in 3 of the regions, they decided to hold off on introducing medication. So the paradigm in the program was to not use them for the first 6 weeks and see who got better. And the Tornio team, this is way north in Finland, right on the border with Sweden, they were one of the regions that held off on using medications, and they really liked that way of working, and they just kept doing that. And that's how they work. That's how their system is organized. So there was they have published now a series of 5-year outcomes. One group is from that original group that was the sort of overall Finnish study, and then they had their own group, did their work, they repeated it again in the early 90s, and then they have another cohort from the early 2000s. And in every study that they do, these aren't large numbers. Altogether, it's less than 100 people. In every study they do, and they've focused on people with first episode psychosis, they've shown these outcomes that I showed you in that first slide, that they have a remarkable number of people getting better, recovering, and very little, very low uses of medications. So what is this? What are they doing? I mean, I've said to you a little bit about it. I'm going to spend a little time going into it in more detail. So the way I organize this in my head is to think about it as both an organization of the mental health care system and then a particular form of psychotherapy, what some people call dialogic practice. And I would say that one can offer dialogic practice independent of the system, but I think I would use the term open dialogue if you're able somehow to get the package of care. And I was watching the movie that was showing earlier on, and I watched it before I came here, and I think that you'll hear some resonance. I think why people like me and many other people are very enthused about this work is that you hear that some of the problems addressed in that in the documentary that we were watching are addressed well. That I think there's a lot of improvement in open dialogue in the way that they've practiced it. So there are 7 principles. If you read some of the articles, Jaakko Seikkala is the chief psychologist and the person probably most associated with open dialogue. He organized their studies. He's written a lot about it. And in his papers, he talks about these 7 principles. And I'm dividing them, again, for the sake of my own making sense of this, into things that have to do with the organization of the system of care, and then things that have to do with the way in which they meet with people. So the way that it's organized is that there's immediate help. If you have a problem in Tornio, you pick up the phone, a senior clinician answers it, and within 24 hours, there is a team that is dispatched to meet with the person at center of concern, and the person and the other people in the social network who are considered to be important. So that's the second principle, this network orientation. So the idea is that these problems are understood in the context of a network. So it can be the family. I've been working with this couple who do similar work in northern Norway, and they were telling me about an instance of a teenager, and someone called because he was having suicidal ideation, and within their first meeting, they asked him who would be important, and he mentioned his friends. So they had meetings with the young man's friends. But the idea is to have this network orientation. Flexibility and mobility is to mean that you meet where it's important for the person to meet. So a lot of meetings are in the home, and it's very much, the idea is, and I think at least where I live, and oftentimes I think in well-meaning ways, we ask people to adapt to our constraints of our system. And here, they just were very mindful from the beginning of setting up a system that allowed them to adapt to the needs of the network that they were trying to work with. It's really quite remarkable, but that's really what they do. Responsibility, I heard someone in the film talking about fragmentation. I know where I work, from the time someone has a crisis to, let's say, the person is connected to a team with whom that person might work, the person may tell their stories multiple times. And here, this responsibility and continuity is that whoever is assigned with the team works with the person through the duration of the crisis. And it's very much a crisis orientation. So it can be varied amounts of time, but the idea is they're going to work through this crisis. And continuity, it's the same team. Now, people may go into a hospital, and there may be a hospital team, but this team that's from the clinic will go and meet with them there. And then the parts that I think more have to do with dialogic practice have to do with an attitude and what I think of as a value system. I'm going to come back to that theme. But so toleration of uncertainty, which is embodied in this idea of need-adapted care. The experts don't so much, come in and sort of tell the person, this is your problem and this is what the treatment is. It's much more of an attitude of, these problems are quite complex. It's hard to understand them, and we're going to sit for a while with the uncertainty of not having a full understanding, not only of what the nature of the problem is, but what might be the best approach. And everybody, I think, again, in the film, we heard about democratic views, listening to people. This is all very resonant with what open dialogue and these associated therapies are really all about. And then the dialogic practice I'm going to get into a little bit more in the next series of slides. So this is from, these key elements of fidelity come from Mary Olson and Jaakko Seikola and Doug Zadonis. Mary Olson is a psychologist based in the United States. She's one of my teachers. She started an institute, a training institute, which I was privileged to attend. And Doug Zadonis is the chair of the Department of Psychiatry at University of Massachusetts Medical Center. And what they're doing there, they've been funded by the Foundation for Excellence in Mental Health Care, and what they've done is to develop fidelity measurements, because there is this growing wave of interest, and the idea is, what is this thing? And open dialogue practices, reflecting therapies, these need-adapted treatments have resisted what you find in a lot of psychotherapies that are tested, which is a manual, and you develop a manual so that you can, if you want to test if something works, you know whether people are doing the thing that you're trying to test. And so there's a real struggle within this community to know how to define it. And I think they worry, and as you hear about it, you'll understand why, that if it gets defined and manualized, that you're going to lose the essence of what's important, because so much of it is a value system. But they did develop these elements of fidelity, and this is available for free. If you Google, I mean, my slides, if you have them, have the website, but if you Google Open Dialogue, UMass Medical School, if you email me, I'll send it to you. You can get this paper. It's a very nice paper that I highly recommend. So again, it goes over how they define this. So they work in teams, which is really critical. 2 or more therapists are involved, and they find that this is really essential to the work that they do. Some of this I've talked about, the participation of the family or social network. And then their style of talking is open-ended questions. They'll start the first meeting with asking, what's the history of the meeting? And everybody in the room has a voice. So that goes down to the next principles, that you really listen carefully to the words people use, their utterances, and try to reflect that back to them. But everybody in the room has a voice, and everybody's voice is respected. It's a very democratic way of being with people. And then you ask, how would you like to use this meeting? And in subsequent meetings, that's how you'll start it. So you begin with asking the people that have come to you, how would you like to use this meeting? And that's just a simple example of something that any of us can quickly integrate into our practice, any of you that are clinicians out there. Then the style of working is to emphasize the present moment. So, you know, I was trained to ask people about their problems that they're coming into, but get a history. And that formal kind of history gathering and formulation of a diagnosis really is not how they work. It's really kind of sticking with the present moment and asking people about what's on their mind. And as I think I mentioned, eliciting multiple viewpoints, and also listening to one's, when you're in a room, you have your own inner voice, what you're thinking about, your outer voice, and you pay attention to this. You may bring in absent family members. What would John say if he were here? It's all about, the point is to have a dialogue, to open up the dialogue. You know, I found in learning this that some of this stuff was familiar to me, but I think my goal of getting people to talk to me was to elicit symptoms so that I could formulate a diagnosis. And what I've tried, and it's hard to undo things when you're at my advanced age and you've done things for a long time, but that really it's the opening up for the sake of opening up, and to sort of sit back on trying to close down into kind of a diagnosis. You creating a relational focus in the dialogue has to do with this dialogic practice. They were very interested in systemic family therapy, and a lot of these kinds of questions came from that. You know, who else agrees? Who wanted to come? Who didn't want to come? This is the kind of thing. A lot of wondering questions. You know, I wonder if, so as opposed to saying to someone, I think this is what's going on, you might introduce an idea you have in this kind of wondering way. And responding to a problem or discourse is meaningful. And I think this refers to the person's experience, the person at the center of concern, well, anyone in the room, as meaningful, as opposed to seeing it as a symptom of a problem that you're trying to treat, that you're interested in the experience that the person's having. Emphasizing the client's own words and stories, I think, you know, I've kind of said that in a different way. And then there's this, and this is what's often very different for people, this reflection among the professionals in the meeting. So that you're there with a team, and during the course of the meeting, you may turn to your colleague and share with your colleague your own thoughts about what you're hearing, what you're wondering about, what you might think about what you're hearing. So the kinds of conversations that clinicians often have after the meeting, you're really talking in the room. And I think what that does, among other things, is to keep you respectful and not objectifying people, which I think is a real risk even among well-intentioned clinicians. And you know, you're just not going to do that when you're sitting with people. Transparency is very much embedded in this, and that also comes out about talking in the room and sharing your questions. And another thing, and I'll get back to this with medications, is that if I'm there with a colleague, we can talk about medicines and everybody can raise their voice, even those who disagree. If I'm as the doctor, thinking that it might be time to start a medicine, and my colleague thinks differently, we're going to have that discussion right there in front of the family and go have that back and forth, which is a really wonderful way of having informed consent, because you're going to talk about the pros and cons in an open, honest way in front of people. And this tolerating uncertainty, that the professionals don't have the answers, they provide a context of safety and making contact with people and talking together about the nature of the problem. So that's how they've developed these fidelity scales, and again, for me, I hope that that enriches, for those of you that are new to these concepts, gives you a broader sense about what it is they're actually doing. So how does this compare to the medical model? It's funny, my husband and I, he's had to hear this talk more times than any human being should have to, and I appreciate his patience. But we've had a lot of discussions about what the medical model means and if it means a thing. But I'm going to define it at least the way I think about it, and I think there is this thing that is different from this other thing that I'm defining today. You might disagree, and maybe that's something that we'll talk about. But at least the way that I was trained, the treatment and the problem was much more focused on an individual. An individual comes into your office and you're trying to understand what's wrong with that person. There's a focus on psychopathology, defining and understanding the nature of the problem. The family would be involved, but kind of as needed, and often in a psychoeducational way. So you're going to educate the family about the problem that you've defined that the person has. That treatments are based on diagnosis. So once you've gone through your evaluative process, you're the expert, someone comes to you, you're giving them the benefit of your expertise, and you're recommending a treatment based on that diagnosis. And I think treatments are seen in a more technological way, and that gets back to even psychotherapies, that it's a thing that you do to someone, and as opposed to something of sort of being with people. So need adapted is, it's focused on the social network from the outset. Diagnosis is held lightly. This uncertainty, we don't really understand these problems well enough to be able to label them in some way that tends to get kind of concretized and reified, like you have schizophrenia, as opposed to you're experiencing something that for complex reasons we're choosing to label, let's say, as schizophrenia. To me, that's a really, maybe it's subtle, but I think that's a really important difference that I think often gets lost today. And that treatment proceeds from the individual network needs. It's flexible. As I said, there's this psychological continuity, and there's this basic therapeutic attitude of being with people and trying to talk together with them about the nature of the problem, as opposed to being the person that comes in and delivers a treatment that's going to fix the problem. So that's how I see these things as fundamentally different. Now, in my sort of journey of exploration here, I've gone back and revisited the whole concept of recovery. And I know that people in Australia are quite familiar with recovery principles, and I think that I'm here talking to a group of people who are promoting this, from what I understand. And I'm going to talk about, what I'm going to say here is that I think that open dialogue is completely consistent with recovery principles. And in fact, for me, what it has done is to help me embody a recovery orientation as a clinician. And I don't think that's always easy to do, or at least it hasn't always been easy for me to do. And what I find very reassuring is to find an echo and a resonance with the values of open dialogue practices and the values embodied by recovery principles. And sometimes people say, well, this isn't anything new, we've known this, and I think that people have known some of this. I don't know that anyone has embodied it in their system of care to the extent that they've been able to do it in Northern Finland, but I think a lot of people know this, and I find that reassuring. I find that that's good news, because it would be, I'd be more skeptical if this was like the only place in the world that they've hit upon this. So what are recovery principles? Now, this comes from the United States, but I know from talking to people that you're very familiar with this, but I used from one of our federal agencies how they define recovery principles. So hope, expect recovery, person-driven, respecting a person's values and wishes, that there's many paths that people can that can improve and recover in a nonlinear way. And what I would add in here is that when you're dealing with psychosis, that 1 or even 2 or even 3 relapses, recurrences, doesn't mean that the person is going to be persistently ill. And we have a system of care that's almost predicated on that if you've had 1 or 2 relapses, and that means that you, for instance, should be on medications the rest of your life. And I think recovery is not as linear as that. That it's holistic, it encompasses all aspects of a person's life. Peer support is important. It's very relational. It embodies the value of social networks, sensitive to cultural context. It's trauma-informed and emphasizes people's strengths and the responsibility of the community and respect, community and social acceptance. And I think if I've done my job tonight that I'm hoping that you hear a resonance between those principles of recovery and what is embodied in the way of being in open dialogue. And if not, maybe that's something that we can come back to and talk about. Now, as I said, there are many other network approaches. Open dialogue was developed in Finland, but there was a resonance, particularly in Northern Europe at the time, of other people working in similar ways. So Tom Anderson, I think I made a mistake, which I didn't correct. I think he was a psychiatrist, actually, and he's from Tromsø, Norway, also very far north in Scandinavia. And he also was interested in Milan systemic family therapy, but similar to the people in Tornio, in the traditional way of working, you have a team that's with the family, and then you have a team that's behind a one-way mirror. And the team that's with the family leaves the room, consults with the team, and then comes back and often sort of has a prescriptive way of working. And they didn't like that. They found that families didn't like it, and so they sort of figuratively broke the mirror. And they all sat together, so those conversations, the reflecting happened in front of the family. Now, when they work, they tend to sort of divide the reflecting, so there's a little technical difference where, I'm worried this is on TV, and my friends who are more experts may say it's not so little. But anyway, they will have a reflecting team that actually talks amongst themselves, and then the group meeting will come back and talk about what they've heard, whereas in open dialogue it tends to be a little bit more fluid. But they're all partners, they meet together, there's a lot of shared information and shared development. So I've talked about this, and Tom Anderson in his writing and all of them have really developed a lot more about what this reflecting is. So when you're talking, whether in an open dialogue way or in a reflecting team, they've elaborated the kinds of things that you're going to pay attention to. Imagery, resonance, any movement that you see among the team. This kind of stuff is what you might tend to share with people. I also wanted to talk about Carina Håkansson in Sweden, who was also heavily influenced by Tom Anderson. She developed the Family Care Foundation. And what they would do is to place people in homes. And I was hearing about work that's been done in Australia that's quite similar to that. But and these would be ordinary homes, and they would take people in there. They'd live with in the home, and then the clinicians would come out and work with the individual and support the family. And they don't use diagnosis. They have helped some people to come off medications. And again, this is just a different model that's heavily informed by this whole kind of value system that I've been describing. And there's now initiatives throughout the world. In the United Kingdom, there's something called peer-supported open dialogue. So I know that there's people with lived experience here, and what some people who've heard about Finnish open dialogue have commented that it is a clinician-driven program, and some people have questioned that. So now there are a number of groups that are bringing peers into the conversation in different ways. And in the United Kingdom, they're developing and they're going to be studying models of care in the NHS, where they are bringing peers and having them have a role in these dialogic meetings. There's a big initiative in Poland. There's a lot of work going on in Germany as well. In the United States, there are 3 main areas that I know of that are doing this work. So there's a program in New York City called the Parachute New York City. I think my colleagues from Advocates and Framing Mess were here about a month ago. Anybody in the audience here? Chris Gordon and Brenda Soar. So I'm going to talk a little bit about what they're doing, and I'll tell you a little bit about what we've been able to do in Vermont. So the Parachute Project, they had a large grant from the federal government. They did this over 5 years, and they trained teams. They brought people from Germany who have been teaching and training this kind of work for a number of years, and they brought them in. They trained people in 5 boroughs of New York, and have been doing this work. I mean, it's a huge project, although New York is a very large city. So they're going to be publishing a white paper on their work, and it will be free and open access is what I've told, and you can learn more about what they've done. They also use that grant to develop peer-run respite centers as well. Advocates in Massachusetts, they got some funding from the Foundation for Excellence in Mental Health Care, and they developed 2 programs, one called Collaborative Pathways, which was geared to work with early episode psychosis, and they're going to be publishing their results shortly. But so I can just tell you about the program. They focused on working with people with early episode psychosis. They tried to use very low doses of medications, and they will be reporting a high retention rate, high patient satisfaction, although they relatively small numbers. I mean, the challenges for all of us is that it's a very labor-intensive process, and it's labor-intensive in getting people trained. So it's hard for those of us in the public sector. It's hard for anyone to get the financial resources to get this up and going. And then they've also used this in what they call community-based flexible supports, which would be analogous to the program that I work with, people sort of in the system that might have some chronic problems in life, and they've been using these teams and working with those people as well. Now, where I'm from, Howard Center, I was able to go to training at the Institute of Dialogic Practice, and some of my colleagues have had training, but really a very few number of people, and our turnover is high. I don't know if you have that problem here. So some of the people that have trained no longer work with us. These are what we're struggling with. But what we've been doing now for close to 2 years is having a Skype supervision with this couple in Norway. And we meet as a team. For a while, they were meeting with a family who was interested in coming in, and they would have a dialogic meeting with them, and then people in the clinic would be reflecting on them. This year, we've just been meeting as a group. So it's been a way, sort of a cost-effective way for me to be able to introduce these ideas to my colleagues. I've also used this way of working with residents. I teach you call them registrars, and so people who have finished medical school and are training in psychiatry. And the traditional way of training in the U.S. would be that the young doctor would go meet with the patient and then come into the room and talk to me later about what they're seeing. And what we do is we meet together and invite in the family. So it's really been a wonderful way of working. So we invite the family, we invite the client, and then the resident, and rather than us talk about them behind their back, we have the conversation that we would normally have without them in front of them and invite them all in. So that's been a lot of fun, I think. And I would say I have not been able to study this, but it feels like there's high consumer satisfaction. People appreciate this way of working. We also have a team that we call the START team, Stabilization and Recovery Team, and this is primarily peers who work as a team in a crisis orientation way. So they will get referrals from our crisis team, from other clinicians, of someone who's having some sort of crisis in their life, and they will go out and meet with them. Now, their training has been in something called intentional peer support, which was developed by a woman, Sherry Mead, who's a social worker with lived experience, and it's a very relational way of working. Again, I I find it reassuring that there's so much resonance with these different kinds of ways of working that have been developed. But the model of it, you know, when I talked about the system, the organization of care, the way of being, it really has a lot of the overlaps that you'll see in the open dialogue model. So, you know, as I said, crisis orientation, home-based, it's flexible, and we have, when we can, have tried to have larger network meetings. But the team really has evolved through the needs of the clients served and the peers, and it doesn't entirely match on to what would be described in an open dialogue model. There are 2 other agencies in Vermont that have been also developing this kind of work, and we are trying, if we can get some funding, to develop a Vermont-based training in open dialogue. And so there's a lot of interest here, but it's challenging. I can come back to some of the challenges that we have. So I want to spend, I think I'm going to talk for about 15 more minutes, and then we'll have plenty of time for conversation, to come back to talking specifically about psychiatry, this thing that I'm calling, I mean, I've stolen the name, I have to say, slow psychiatry, but what is that all about? Because, you know, I'm a psychiatrist, so first and foremost, I'm really thinking about my responsibility and not wanting to do harm. I really worry a lot that if you were to weigh the balance of my career and the benefit that I've been able to offer people in harm, I'm not sure a lot of days where that balance is. And so this is something I think about in reshifting the way that I do work. So what are the challenges of this kind of work in psychiatry? So time constraints, you need to take your time, and that's part of the slowness. Psychiatrists in the U.S. are limited resources. We're quite expensive, and so in an agency there's a tendency to have us see people for, you know, very quick, short visits so that we can see a lot of people. And if you're going to shift out from that, that's going to raise some problems. But also, I think it's the mindset of psychiatry. We are the experts. People view us as the experts. We're the ones that are the expert in diagnosis. We're asked, in certainly my country, and I think here, to be the experts on things like dangerousness, and we are perceived as the team leader. So it's a shift in an attitude to be able to sit in a room and to try to actively give up that expertise role and that leadership role. What are the advantages? I mean, personally, I think uncertainty should come naturally to psychiatrists, because I think that we don't really know. I think I alluded to diagnosis being reified. I mean, that book, the DSM that we use in America, was begun as kind of a placeholder. You know, it was meant to say these are categories, we're likely heterogeneous, and we're going to use these categories, and maybe over time we will be able to find some sort of specific pathophysiology, and we've not found that. That day has not come to fruition. My own view is that the more we look at neuroscience and genetics, what we come up with is more complexity and further heterogeneity. And I think there's treatment uncertainty. I alluded early on in my frustrations and really anger over the incursion of commercial interest on the field, and I think that the drugs that we promote and use are not nearly as effective as most people have come to believe they are, and I think they come with a host of dangers and risks. So I think uncertainty is where psychiatry, in my view, should be comfortable, because there is so much uncertainty. So the principles of open dialogue that I went over, the fidelity measures, and are really silent on the use of drugs. And given the complexity of this treatment model and the way that it's studied, we really don't know if the low dose that they used or the avoidance impacted outcome, whether that contributed to the outcome. I worry, I mean, I think that it probably did, and I worry that as this approach gains widespread approval, that if it gets married with the current way that we use drugs, that we are at risk of maybe not seeing the kinds of outcomes that they've seen there. So I think that psychiatrists who become interested need to shift to a more cautious stance in how we use these drugs. my idea here is that the way to resolve some of the conflicts of psychiatry with this kind of approach is to narrow our focus. That in my view, in the course of time that I've been a psychiatrist, what I've seen is an ever-broadening focus of psychiatry on the problems of living. And this got a lot of attention when the latest edition of the DSM came out, DSM-5, and controversies over how broad, you know, the problems are, that almost anyone at some point could come under the purview of psychiatry. And so you then have this kind of situation where there's a very broad purview of what sort of ripe for psychiatric attention, but then there aren't enough psychiatrists and very expensive, so people sort of get in very quickly, and I think at the risk of getting in very superficially involved with people and doing whatever it is we do. So I have this notion that we should contract what we're doing and really pay attention to a much narrower group of people to remain being experts on psychoactive drugs, but to do it in what I'm going to go into this more, as psychiatrist Joanna Moncrief has called a drug-centered approach. And that when we do get involved with people, we take our time and get involved with them in a much slower way. So the idea is that we contract who we're seeing. There's a lot of other people out there that I think can help the vast majority of people, non-medical clinicians and peers, who can help a lot of people resolve their crisis without needing to bring it into the realm of the medical world. But there may be a group of people who might benefit from medical world, but from the medical view, but to do it in a somewhat different way that I'm going to describe. And so the idea is to take our time and to be humble. So what is this disease-centered, this drug-centered approach that I'm talking about? So this is taken from a psychiatrist in England, Joanna Moncrief. She's written a lot. She does also blog Man America. She has her own blog, and her most recent book is called The Bitterest Pills, which is a specific focus on the antipsychotic drugs. And she's made this distinction between a disease-centered and a drug-centered approach to using these drugs. And in a disease-centered approach, the idea is that the drugs are correcting an abnormal brain chemistry, and that they're medical treatments, that they're specific to some particular disorder, and the beneficial effects of the drugs are derived from a presumed effect on this specific disease process. So that's really today how a lot of people think about the drugs that psychiatrists prescribe. Whereas in a drug-centered approach, the idea is that the drugs create an abnormal brain state, that they're conceptualized as fundamentally as psychoactive substances, and that they alter the expression of psychiatric problems through the superimposition of these drug-induced effects. So it's a fundamentally different way of thinking about how these drugs work. So in a disease-centered way, you're going to think about drugs having a main effects, and those are the effects on the presumed disease target versus side effects, which are sort of unwanted side effects that, as I said, they treat a specific disease, whereas in a drug-centered approach, the drugs are considered to have these broad psychoactive effects, and that some of those effects might be useful in some context. Now, in a disease-centered approach, you're more likely to consider the long-term poor outcomes as a consequences of this underlying disease process. I think this very much happened with the concept of schizophrenia, that it became conceptualized as a chronic condition with a deteriorating course, so that when people had a poor outcome, it was assumed to have to do with that underlying course. If one takes a drug-centered approach and you start to see people doing poorly, you think, boy, I've added this drug into the mix of things. I think you're more likely to wonder and pay attention to and study whether the drug itself could be having these effects. And in a disease-centered approach, you're more likely to consider the recurrence of illness, that you're more likely to think about a recurrence of this underlying disease process when the drug is stopped, whereas in a drug-centered approach, you're more likely to think about the effects of withdrawing a drug from the brain and wonder whether you may be seeing withdrawal effects. And that idea has largely been ignored in psychiatry, I think, in the past 20 years. So the idea of bringing this together is that psychiatrists do remain experts let me just, I want to say one thing here. I'm sorry. I just want to, before I move on, say a little bit more about the drug-centered approach and talk specifically about antipsychotic drugs. I thought I had that slide here, but I don't. So if you apply that to antipsychotic drugs in a disease-centered approach, you're going to say there's a condition that we are calling schizophrenia, and these drugs are specific to that, and they're correcting it. They're correcting something in the brain. And this disorder by many people has been conceptualized as a chronic condition, so we might not expect people to do better, to recover, and we might not think that the drugs are having much impact on recovery. And when we stop the drugs, we're thinking that when people relapse or have a recurrence of problems like voices and hallucinations, we're thinking that that is because we've stopped treating the illness and the illness has recurred. But in a drug-centered approach, we might look back on what we knew about these drugs when they were first discovered. And when they were first discovered, what they were described as causing is indifference. That's what got people's attention. When they're given to normal volunteers, what they do is cause an apathy, a kind of reduction of volition. And so in a drug-centered approach, when people are on these drugs for a long time, you might anticipate that over time you may see impairments in recovery because the drugs themselves are causing some apathy. And you might worry that that could hinder recovery. So that shows you in that particular instance the difference in how one would think about these drugs, how one might study them, how one might be concerned. And the other thing is that when you stop them and a person gets symptoms again, you might wonder whether that's related to the impact these drugs have on the brain, that it might create a situation a person might be more vulnerable to having symptoms again. So that shows you the difference. I'd say another way to think about this, and I think it's a lot easier to think about it in drugs that people like to take. So with alcohol, we don't think that, alcohol is a psychoactive substance, and it has a lot of problems. And some people get addicted, some people abuse it. It has effects on the brain in terms of memory. It has effects on the liver. However, there's a lot of people that are able to have alcohol intermittently through their lives and not have bad outcomes from it. And there are people who you might say benefit from it. Someone who is a little bit anxious in social situations and has a glass or half a glass of wine to be able to be more comfortable in a cocktail party is having the beneficial psychoactive effect. You could probably design a study to show efficacy of alcohol in treating cases of social anxiety disorder. But we don't think about the drug correcting social anxiety disorder. We think that we're exploiting the psychoactive effects of that drug in certain instances in certain people to have beneficial effects. So that would be a drug-centered way of thinking about that. So how does this get integrated? I'm proposing that psychiatrists take a drug-centered approach to understand drug action in their way of being with people, that we are honest and humble about, we're honest about what we don't know, the many areas of uncertainty that are continuing to be a part of what our profession is, that we listen to what a person wants and values, that our treatment orientation has tended to be focused on symptoms and reduction of symptoms, and that may not be the most important thing for the individual, for the family, the carers. I love that term. That's not a term that's common in the US. And so you listen together about what is most important as opposed to telling people what you think is most important for them, and that we bring many perspectives into the decision-making process. And that's this idea of slow psychiatry. It's an analogy to the slow food movement that pushes back against industrial agriculture. Industrial agriculture tends to value production, which in this analogy would be symptom reduction above all else. And the slow food movement values the environment, the experience and cultural significance of food, and I think the analogy here is to have a more holistic approach and understanding people in their context and people's individual values and what's most important for the individual. And this constriction of psychiatry's purview Doesn't mean that you give us 15 minutes to be with someone, but we see a lot fewer people. Let other people be involved. I think the majority of people with the kinds of distress that right now are at risk of falling under the umbrella of psychiatry don't need to see a medical person. But when a medical person is involved, it's hard to get to know another person and their system, and let's take our time and do it in a more careful, honest way. So I'm going to stop at that point. I do have other slides, but I'm going to conclude the sort of formal presentation, and hopefully we'll have some kind of dialogue in this room today. So thank you very much.
Thank you. Oh, I can hear you now. So, have you been filing those questions away? So we've got some time. We've got Sandy. Do we have a question to start off with?
Yes.
Yep. We can have people with microphones. Are you reading mine? I can give it to you.
And I mean, if you're comfortable introducing yourself and saying why you're here, you know, what would be a good use of this time for you? I'd love to hear that, but I don't want to put anyone on the spot either.
Yes, hi, my name's Robin. I'm a psychologist and also the mother of a son with schizophrenia. I suppose my question is, how did you promote this system? How did you get this system into the health system in your state? How did that occur? Because I think that's a question that a lot of us here are wondering.
Well, I just want to be honest, you know, this thing about humility is in that we're in the process of doing this, and I'd say we're early in the process, but a couple things happened, which is one of them was an act of nature, which is that we had in Vermont one state hospital, which as of 2011 had about 50 people in it. And there was a hurricane, what you would be called a cyclone here. And even though we're inland, there is a river behind this hospital, and this hurricane caused a flood, and it flooded the hospital. People had to evacuate the bottom floor. The lights went out. It was very dramatic. And the next day, the hospital was evacuated. Now, this was a state hospital that in its peak in 2000 had, I think, about 2,000 people. A lot of the buildings had been closed down, and it was and converted to state offices, and there was just this 50-bed hospital. Now, Vermont has a very progressive history. There was a remarkable psychiatrist in the 50s, George Brooks, who developed this very innovative, recovery-oriented rehabilitation program. And then a woman, a Professor Courtney Harding, studied outcomes of people who had been in that program 20 years later and found that 2/3 of the people were recovered. And her work really was a part of the beginning of the recovery movement in the 90s, but it was not embraced throughout the United States. But because her work was in Vermont, people knew about that. And so there was a large group of people who've been very progressive, very community-oriented, and many of them wanted to close down the state hospital. But it was the usual back and forth, because there were other people that said, no, 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 we need a hospital, you know. So when this happened, there was not only a flood to the hospital, but a little brief moment of flood of money. I hope I don't get it if people in Vermont ever watch this. You know, a flood of money to the community mental health centers, and we were able to use it. It's what funded my training. It's what funded the START program that I described, some very innovative programs. And the other agencies, there are 2 other agencies that are doing something. They took the money because it happened right after a lot of us had read Anatomy of an Epidemic. And I was starting to read about open dialogue and getting very excited about this. So it was informed by our very early conceptualization. So that's how that started. But it's an ongoing struggle to try to figure out how to do it. And my own personal philosophy, that's why I don't like to use the word open dialogue. I've shifted to need adaptive, because I really respect the people that I've learned from and the work that I do, and I feel like I'm approximating it, so I don't want to if I do it poorly, I don't want to give it a bad name. But, you know, there's a saying, don't let the best be the enemy of the good. I mean, I'm trying in my own way to bring it in when I can. And so I would say it's open dialogue informed practice. And it's recovery-oriented practice. I mean, that's what I really want to promote. And like I said before, to me, I think a lot of people that hear about this, like, it's gotten a lot of attention about the medications, and that's something I'm not going to let go, because as a psychiatrist, I feel like I have to be an expert on those drugs. But I think it's really a great way of working, even if their outcomes were about the same, because having people feel listened to and having people be a part of the process and having a system that's flexible to the needs is not a controversial idea. And I don't want to let go of that. I don't know if that's answered your question, but thank you. Yeah?
Hi, I'm Kel. I work in a youth early psychosis program at the moment.
Yeah.
I guess all of this, it all sounds really wonderful, and I think it's something that most workers would embody. But when it comes down to the actual practice, everything seems to be dominated by risk and concerns around risk. Do you have any kind of advice, I guess, in trying to move, obviously risk is important and mitigating that's important, but to try and move away from that into a more kind of humanistic framework?
When you've heard about my whirlwind visit to Australia, and I started out in Perth and at the Western Australian Mental Health Association of Mental Health meeting, and they had a guy named Mike Slade from Britain come, who's I guess been in Australia quite a bit, and he gave a really wonderful talk on recovery work, and I'm pretty sure it was in his talk that he talked about the dignity of risk and having to understand that I think a system of care that's only based on minimizing risk has its own risk of doing harm. And I think having those conversations about the dignity of risk and, you know, who gets to choose. I do think that this framework of talking is a good way to talk about it, because you can sit with people, let's say if you're talking about going into the hospital, you can have everyone in the room and you can say to someone, I'm worried for you, and this is why, and hearing everybody's voice and maybe coming to some sort of compromise within that, or at least being transparent about why you're doing what you're doing. I think you know, I am part of the coercive system of care. In my state, I do sometimes commit people to hospitals, and I want to be honest about that, but I like this framework rather than of being able to bring in as many voices as possible, so that you can have a conversation. A lot of times, you know, risk assessment is such a subjective thing. I mean, there's some cases, and a lot of times when you, in my experience, when you have people that are talking about risk as like the thing, they'll bring up some very dramatic situation. You know, someone's, you know, on a bridge and one leg is over the bridge, and, you know, it's very scary and worrisome. But a lot of times it's more ambiguous than that, and you're worried. Someone's judgment seems to be impaired, and so you're worried about what they most do. There's nothing wrong with those worries, but we're really pretty poor at predicting dangerousness, and yet I know in the US, our systems of involuntary treatment are all predicated on predictions of risk. So, you know, I think there is a lot of room for bringing in a lot of voices and trying to talk together and maybe making a more sort of democratic decision, or at least a decision that's transparent with people. So I don't have an answer, but that's at least the way I think about it. It's a very important question. Yes?
I want to follow up on that risk question too.
I'm just a dumb guy carrying the mic, so I'm actually...
You can hear me? I'm a carer, and I went through with my daughter the 5 years trying to access around 5-6 years of fantastic listening psychiatrist. But not only was he in the hospital, he was checking all the drugs and trying to why is this going on, but he was in the community, and he was at a place called Living Skills, which was very peer focused, it was very recovery orientated. And it got closed down because of risk, the risk issue. And I asked the guy who had been working there for 25 years as a rehab officer, how many times has there been a severe risk? And he said, well, in 25 years, a couple of times I've had to take a couple of chaps outside, have a little talk and calm them down, but I've never had an incident. So the perception of risk is often much, much higher. And then, you know, nobody looks at the risk of the drug reactions. Like toxicity and delirium is a huge risk. Right? So I really like to expand on that risk question a bit more.
Yeah, I mean, I'm not sure how to expand, but one thing that I will say is, you know, in another version of this talk, I talk about how it came to be that we recommend antipsychotic drugs long term, and I think risk is part of that story. And the reason why we do that is that we did these studies called the relapse studies, a whole series of studies where you take a group of people and you treat them for some period of time, let's say 6 months, and then you divide them up, and one group stops the drug and the other group continues on them. And what was found in repeated studies that the group that stops has a much higher risk of relapse, a recurrence of symptoms, a very symptom-focused view than the group that stays on the drug. And the difference is something like 70% relapse in the group that stops versus about 40%, something like that. And there's been meta-analysis. So that is what got translated into everybody needs to be on drugs forever and ever. That's a very risk-averse thing, taking relapse as the most primary thing. Now, what I would say about these studies is, first of all, there's another way of looking at it, which is that about 30% of people don't relapse if the drugs are stopped, and about 40% of people relapse even when they're on the drugs, 30–40%. So there's really only about 40% of people that are really benefiting from the drug. It's just that it's very hard to know upfront who they are. Now, I think that relapse can be a risk for some people. There's no question in my mind. I've seen some people who get really into a lot of trouble, and sometimes when they're most in need is when they don't really want to have anything to do with us. So you may have a really good treatment relationship at some point, and then there's another point where it's as if you've never met, and then people can get into harm's way. And that's kind of the, you know, what most people think about when they say relapse prevention is the highest priority. But first of all, that's not true for everybody. There are some people, I've been doing this drug tapering protocol in my practice, so for the past 5 years keeping track of this. You know, some people will call me up on the phone and say, you know, I'm uncomfortable, the voices are louder, I think I need to go back up on the dose, and we'll say fine, and other people are okay. I mean, there's stories, all different kinds of stories, but we make a treatment plan for everybody based on sort of one kind of outcome. And then we minimize other kinds of risks, and the common ones, which we know about tardive dyskinesia, these days weight gain and all the health impacts of, you know, high blood pressure and diabetes that are associated with the drugs. But the risk that, and this is, you know, what Robert Whitaker brought up in his book, and there's some newer studies that support it, these risks of impairing functional outcome. There was a study out of the Netherlands, the lead author is Lex Wonderink, and he compared two protocols. One was to keep people on medications long term, the other was to stop it and then start it if people had symptoms. And what he found when he tracked people, at 2 years he found that the group on intermittent treatment had a higher relapse rate, but at 7 years what he found was, first of all, the relapse rate, they catch up to each other. So it looks like the drugs just postpone relapse rather than absolutely prevent it, but a much higher rate of recovery in the group that's on this intermittent treatment and on lower dose. There's a study that came out of Australia, Patrick McGorry's group, that did a similar thing, a much smaller study. Jake is it Jay Gleason, is a lead author. They did a study where they gave people psychosocial intervention to improve adherence. And again, they found that group was less likely to relapse at, I believe, the 12-month mark, but at 30 months, the groups had evened up. But the group that was more adherent had a worse functional outcome. And it was related to adherence. So the more adherent you were, the worse functional outcome. So that's another risk. So, you know, what I think is we got to look at all of the risk and, again, make a very individualized decision that respects the individual and the carers, because they may not be in alignment, but I think all their voices are pretty important. At least give people the opportunity to hear this data and talk together about what makes the most sense. And that's where I think that the open dialogue kind of paradigm is a great setting for what I think informed consent really needs to be, which is an ongoing, repeated discussion about complex issues that are really embedded into the relationship that you have with the person and his social network. It gives you a framework of doing that. Informed consent isn't sort of one day you say this and then you go off. It's what you do. It's what, to me, I think the doctor-patient relationship is all about. Yes?
It's very nerve-wracking. Hi, my name's Abby. I'm an occupational therapist at the inpatient ward at Royal Prince Alfred Hospital. And I was just wondering what recommendations you would have to implement this framework that is very patient-centered in an acute inpatient setting. I think that's one of the challenges that we often face, is a setting where unfortunately people are brought in against their wills on many occasions and don't want to be there, and it's a daily struggle that we have maintaining client-centered practice whilst complying with certain legal things. So I was just wondering if you had any experience with people that had implemented it in inpatient wards, or what recommendations or advice you would have.
Yeah. So, I mean, I don't work in an inpatient ward anymore, but there is a guy, a psychiatrist, German psychiatrist, Werner Schütze, who is in Germany and is part of this network, and he's been doing training for years in inpatient settings. He's come, I know him from these meetings, and he's come to Vermont and done some training and talked about that. I think it's harder, certainly, because you're really at that moment of crisis where people may feel most alienated, but one of the core concepts of this work is it is working in the crisis is really valuable. And that's another shift that I probably didn't emphasize as much as I should. You don't wait for the person to sort of calm down. You get in there right in the crisis. That there's a lot that you can learn. So I don't know how your unit works, but for instance, a lot of units where I've worked, rounding is a really important part of what you do. So the team will go meet with someone, but then the team goes off behind closed doors and has a lot of conversation about that person. So one simple thing you can do is bring the person in the room and invite the family in as kind of a core thing that you're doing. I did, you know, back in the 70s, I worked at a state hospital when I was a resident. And I worked with this really wonderful psychiatrist, and he was doing that. I mean, I don't know how he got this idea. I mean, it was his idea, but he would bring someone into the room, and the team would talk, but the team included the person at the center of concern. And in a way, it makes so much sense. So that's one way that you could, it's just opening it up a bit, and again, being honest. I went to do a kind of case presentation at our state hospital, and we brought in a gentleman who had been there at the time. He was in another residence, and we did a kind of dialogic meeting with him, and then the staff looked on. And it's a guy who really can be kind of intimidating to me and to others, and he just loved it. Now, I don't want to pretend to say I'm an expert in doing this. It was one moment, and I again would be humble about it, but he felt so, he just seemed to really appreciate being able to talk to this group of people. And one of the things that happened in the meeting is I remember I said to him at one point, you know, sometimes when you're a certain way, you scare me, and you've scared other people. And that's something, we were talking about him leaving the hospital and being in the community. I don't want to say too much about him. And then what he said to me is, you know, you scare me. You know, you have the ability to lock me up, and you have the ability to make me take medications. And that frightens me, and that's going to cause me to act a certain way when you're with me. And it was said to me and everyone, it was like, yeah. And it was a really nice moment where we could sort of collectively share our fears, you know, together. And that was so anyway, that's a little anecdote.
We've got 1, 2, 3, and I think there was one there. Yes, you. So you can work your way forward and come to the back.
Actually, I just wanted to follow up on that and then ask another question.
Sure.
So the follow-up, I guess, comment was that because I work in systemic advocacy with mental health consumers, and in the inpatient hospitals here, we get some feedback that people can't access their medical records and the notes that staff write about them. And the feedback we've got about why people do that is that staff feel that the consumers might feel aggravated, or you know, it might make them actually feel worse about themselves in a way, and affect their recovery. So what would be your response to that?
I think that, I mean, this won't shock you to hear the answer, but I think we should write our notes in a way that would allow someone to hear them. And I think, I mean, I would challenge someone to sort of test that hypothesis. But I think it does speak to how what's happened in clinical work, which is to talk about the person as the other and talk about them in, you know, less humanistic terms. One of my many wonderful teachers is a psychiatrist, Birgitta Alekär, who was the chief psychiatrist in the hospital in Finland, where they were developing open dialogue. And she said at one point, like, we were there learning, we said, you mean you never talk about the person when they're not there? Because part of their principles is that the conversation occurs with the person. Again, you get into recovery and the peer movement, nothing about us without us. That's a big thing in disability rights in the United States. And so people said, really? And she's, you know, she said, well, you know, sometimes we do, but I don't like the way the conversation goes every time we do that. And I just think there's, and this is among good people, there's a tendency to sort of, to blame the person. You know, if your treatments aren't working, you know, something that, a phrase that has really gotten under my skin in the United States is, and it's now antiquated because of the new DSM, but someone would say, maybe there's a little axis 2 going on there. Does this have any resonance here? So the idea was the old DSM, axis 1 would be, you know, schizophrenia and bipolar disorder, and axis 2 were the personality disorders. Now they're all one axis. But the idea is if someone isn't getting better, it's because they have a problem that's not treatable. That's really what you're saying. And, you know, as opposed to maybe your treatments don't work. So I think, I would personally think it's a good exercise to write your notes as if the person is listening. And I would really challenge someone to say, what is it that you feel you can't say? Because I think that's a worry, like I'm going to be constrained in some way. But I think it would be a really excellent exercise to do that. And again, am I perfect in this way? I'm sure I'm not. You know, notes are, you know, this thing that you're doing sometimes late at night, and, you know, but it's an exercise in what your values are and your attitude.
And my original question was about what you said about narrowing psychiatrists' focus.
Yeah.
Do you have any advice about that? Like, what kind of work do you feel psychiatrists are doing that they don't really need to be involved in at the moment?
Well, I mean, what's happened in the United States is that sort of almost every form of human distress has become encapsulated under some sort of label, and that then has a drug target. And the pharmaceutical companies are, you know, these enormously successful businesses. And in the U.S. we have direct-to-consumer advertising. So, you know, it's not just in psychiatry, but sort of every kind of problem gets an acronym and a website and, you know, people coming in there. And I don't think that, I don't think our what we have to offer, and here I'm talking about specifically drug treatments are often that great. So for instance, in the big realm of depression and anxiety, if you know, there's now data looking at the efficacy of the antidepressants, let's say on depression. And when you look at the whole collection of studies, including studies that were not published, in order to get approval by our Food and Drug, the FDA, Food and Drug Administration, thank you. Thank you, dear. You need to have 2 positive studies. It turns out that some of the companies have run 6 studies, 4 of them are negative, don't show positive effects, 2 show positive effects, and the drug gets approved. So people have now gone back and gotten access to all the studies, and when you look at the whole collection of studies, it turns out that this modern class of antidepressants, Prozac, the SSRIs, just aren't that effective. Maybe they have some efficacy for people with the most extreme forms of depression. So that takes out a whole big body of people that are, you know, seeing psychiatrists or coming under the purview of psychiatry that I think might do better with other kinds of approaches, and then that would save them the many side effects associated with these drugs, and, you know, et cetera, et cetera. You know, similarly with anxiety, I just don't think that the drugs are nearly as effective as people have come to see. I just don't think the model of a molecule impacting these very complex human behaviors has really borne out to the extent that people think it has. And it's a downward spiral, because, you know, people think they're effective, and then they think they're more effective they are and less dangerous than they are, so it really lowers the threshold of people getting exposed to them. So that's one area where, you know.
To you, and then to Al.
And let me just say, I think with psychosis, I would not assume that everybody needs them, that everybody needs them long term, you know, everything that I've said. So that's the area that I sort of held on to the most. And even within sort of the psychosis area, I think there could be a contraction as well in what we're doing. Yes?
Hi, thanks very much for a really interesting talk.
Thank you.
My name's Amanda. I work in psychiatry and mental health education. And I just want to pick up on this idea of the slow food movement, which I think is really lovely. I'm also an anthropologist, but the slow food movement started out locally and then grew globally.
Yeah.
And I'm just thinking that some of the approaches that you've described in open dialogue seem to also have a cultural orientation, if they're drawing on some of the best aspects, if you like, of traditional or cultural models of care that emphasise, you know, the group and the individual within a particular context. So firstly, I'm just wondering whether part of the approach has borrowed from traditional models of care, and whether you can identify those. And secondly, how does it resonate? How does it sit with working in diverse communities or with Indigenous people? Yeah. And the flip side of that question really is, have you actually come up against any resistance to working in a slow way, in a positivist tradition where people expect results from medicine and from psychiatry? Yeah. And then the third part is really around...
Well, can I answer because my memory isn't great. Can I? These are great questions. Great. Can you save it, and then I'll come back to it? So, I mean, I don't think that this was developed. I don't think that, to the best of my reading about the development, that it was influenced by sort of traditional ways. The influences were from, there were a psychoanalyst involved, systemic family therapist, and then there is a philosopher, Mikhail Bakhtin, who's Russian, and he was very interested in Dostoevsky's novels, and the way in which there were multiple voices. I mean, I haven't gone back to read this in these years since I learned about this, but in his books, he'll sort of, Dostoevsky will play out the inner and outer monologue of the characters and sort of show how sort of demonstrate how there are these complicated interactions between the different characters. And Bakhtin noted that and wrote about that, and wrote about these concepts of polyphony and multiple voices. And I know that, you know, Finland shares a large border with Russia than the Soviet Union, and there was a lot more, what they've explained to me, a lot more kind of intellectual interchange between those two countries than there were, let's say, with like the United States and the Soviet Union during this time. So that was a big influence. But I don't want to, it would be, you know, sort of rude of me to sort of have to speak with any kind of knowledge or expertise about your country. But when I was in Perth, there were a bunch of workshops on indigenous cultures, and Pat Dudgeon, who I assume people know, gave a really wonderful keynote address, and then there was a yarning circle that was held, and then we were allowed to sit around and watch it. And one thing, at least that I took, I'm paraphrasing her, so I apologize if I'm getting this wrong, but what I thought she was saying is, you know, first of all, don't come in and try to fix us, that we have a lot of knowledge. But she also said, I think we might have something to teach you. And then when I was watching the yarning circle, and I did this like Twitter, that was a dialogic meeting. And there's a woman named Flick Gray, although I guess Flick is her nickname, and she's now studying in England. I think there's a training program there, and it's now on YouTube or on the Man America website. She is talking about this. She said, you know, people are asking me why I'm going to England to learn something that people in my own country have known for a long time, and she has a very eloquent discussion of this whole issue. So I think it's there. It is kind of like we, you know, I'm a child of positivism, I guess. You know, I didn't even really know it. You know, social constructivism, all that stuff is stuff I came to quite late, and I'm really a student. But you know, my generation, that's how I came up, and I think that we were hoping that we would figure it all out. You know, we were so darn smart, and we would be able to figure these problems out. And I think these other ways of thinking and relating, I think, have a lot to teach us. So I think did I get to your first two questions? Okay, give me number 3. I knew I would forget, so.
And just a very brief comment.
Yeah, no, please.
You've been talking around the point, but really trying to say that there's been a lot of medicalisation that's been happening where psychiatry is kind of encroaching on everyday life.
Yeah.
And I'm just wondering, paradoxically, how when in moving from a disease-centred to a drug-centred, you're actually going to reduce medicalisation, but still be using drugs, which I think is really just an interesting comment on the process itself. And it'd be interesting to see how that plays out.
Yeah, and that's, again, I've given sort of different versions, but like one version of this drug has to do with just the medicalization. I think it happened in psychiatry for a lot of reasons. I think one was just an earnest hopefulness, you know, an earnest, well-meaning hopefulness. I think another was to legitimize ourselves with our peers, because psychiatry has been looked at askance at, you know, and so, and then I think it sort of, it got combined, at least in the U.S., with the force and money of pharma. I mean, that's how I think all this happened. And I sort of lost the second part of this thought here. But yeah, I think it's a way to, I think people are going to want to use drugs. Drugs are going to be made. People have used drugs, you know, for a long, long time. Before there was psychiatry, people are interested in psychoactive drugs. And so I think it's a good idea that there is a branch of medicine that's really an expert on what these drugs do. I think that is a valuable contribution. It's just doing it in a much more narrow, humble, honest way. And so, yeah, I think that was, thank you for picking up on that.
So we'll just do Alan and this lady at the back. Oh, Cass just put her hand too. We'll try and get out by 8, so.
Okay, thank you for your excellent questions.
I'll try to finish by my first question by 8. Sorry, guys. I really love that question. I really love the answer. So
thank you.
Thank you both. I'm Alan Rosen. I'm a community psychiatrist. In many ways, I feel like I've been on a parallel journey all my life as a recovering psychiatrist. But also with social anthropology.
Brother from another mother.
Training. So I really groove to what was just said there, and how we need to learn back from our Indigenous people what, you know, some of the traditional healing factors that we don't use routinely that we could use in our wider community. So, but what I really liked also was what you said about don't let the best be the enemy of the good, and the issue about not having to be perfect. And in a sense, the context in which the Finnish system has been developed and those even the fidelity criteria are not evidence-based, and the studies are yet to come in. So that's why I guess we're looking to the wider studies like the New York City parachute study and the UK peer-assisted study. So I think that all these things are really, really crucial, and particularly in the context where there are people who are now starting to develop open dialogue networks. We have a community of practice of the HIAP teams, of the early intervention teams around Australia. We have a team forming, a research team forming in Origin to look at doing a form of this, which may be similar to the UK or the New York study, and may in fact become another site for one of those studies. But we're exploring all those things at the moment. We also have Professor Niels Boos here, who I think we should introduce. Just put up your hand, Niels, because he's our new Professor of Mental Health Nursing here, who's also on this trajectory. So there are things happening, and I know other people are doing things in other contexts. But the issue is, do we have to do it perfectly? And in Finland, you generally have to do a 3 or 4 year psychotherapy degree. You have to, or you're expected to. You have much vaster size teams than we have for a small population. It's only got 20,000 people in it, and the hinterland isn't that much bigger. And so doing it in complex contexts like urban centres and tough regions and so on, with homelessness, etc. These are, I think, challenges as well as being on it. But I think sometimes things develop in easier contexts in some ways. Rural remote is also a big challenge for us. So just these issues, how do we handle these imperfections where you can't have a big team, you can't train them for use in psychotherapy or family therapy, although I've been working with a team for years that had the benefit of the Tom Anderson approach and Harleen Anderson and the family system stuff, but you lose that after a while here because your community teams get contracted quite often. So we're in a context where we don't have huge resources, and we have care coordinators, case managers who also already complain about whether they can cope with the caseloads they've got. So what do you do? How do you do these things in imperfect contexts? You have touched on them.
Well, I can tell you that like the parachute training and other trains have greatly condensed that. In part, my understanding of the 3-year training was to model the criteria in Finland to get their certification. So I'm not saying it didn't require that, but that didn't sort of generate completely de novo itself. And also, I forgot to mention another initiative in the U.S. is going to be in Atlanta, Georgia, also funded by the Foundation of Excellence in Mental Health Care. I'm on their board, so I guess I'm promoting them a little bit, but I'm very proud of the work they're doing. And it's going to be an implementation project with Mary Olson, Doug Zadonis, and Jaakko Seikola. And from what, I can't remember the exact hours, but they've condensed their training to be able to sort of implement this in a public mental health center, in a big urban center. So I think we're going to be learning a lot, but the training that we're talking about in the U.S. is going to be something like 16 days, which models more of what they were doing in Parachute. I just think we're either not going to be able to do this, or we're going to have to, bring it down to that and then learn from it and learn what we're getting at. And it's great to have a professor of mental health nursing. Nurses are at the center of this work in Tornio, and I've met a few of you in this country who are really outstanding. So I just think, in my experience, I'm not intending to pander, but it's a little bit of pandering, is that, doctors come in for like a minute, and it's the people on the wards that are really getting to know people. So I think there's really a great area to bring nursing and other, mental health professionals into this work, because they really are spending a lot more time with people.
So we'll take one more question from the back, and if there's a short question and a short answer. But Sandy will be here, she won't run away, so if you have any other questions, I'm sure she'll be happy to talk to you afterwards.
Quite short.
Ah, well, sorry, sir, I'm being democratic.
Hi, my name is Kath Thorburn, and I work as a mental health worker in the public system, but I also have a small organisation. And you know, I guess I've been thinking about open dialogue for a little while now, and something that really stood out to me when I was, I think, first got introduced to the idea. I don't know if it was something that Jaco had said or something that Mary Olsen had said in an interview, that they talked about the idea that psychosis, rather than occurring within the person, seeing it as occurring in the space between. And for me, that idea has been very helpful in kind of making very clear all the reasons why you don't do anything behind closed doors and why you have that open dialogue. And I'm just wondering if you could say a little bit more about that, and I guess whether that's how you see it as well, and what that might mean for, because I think kind of in terms of understanding the subtlety, you know, we look at this, you know, the fidelity criteria and go, oh yeah, we do that and we do that and we do a bit of this too. But I think there's some real essence of this process that's very nuanced.
Yeah,
and very complex.
So yes, I'm familiar with that idea, and I'll be really honest. I think it's an idea that I've personally had to kind of wrestle with, because, you know, like I said, I'm a more concrete kind of person, and, you know, I do come from a certain kind of tradition, sort of a materialist, you know, tradition, and so this idea of it being between, it definitely is not something that I have to say I kind of understood, and certainly I'm not sure that I'm the best person to convey it, but I'll let you know how I've made sense of that, which is that, you know, Mary Olsen's training was in communications, and I think it's about communications and how much of human experience has to do with conversation, talk, words, and how we communicate with one another, and that by seeing it as the process of communication, how people make sense of their world and the words that they use to talk about it is, you know, we can pay attention to it, and through these conversations, you may shift to having a different understanding of your work. There's a paper that Jaco published about a man that comes in and had some paranoia, and in this paper, he goes back to what he was thinking at the moment that he suddenly thought that something bad was happening to him. And they just talked about it, and he was able to kind of get back and see it in a different way. I know narrative therapy had its roots in this country, and I think there's some overlap today. What stories you tell yourself or the way you talk about your problem then impacts how you feel. So I think it's kind of in that realm, but also I know in one of Jaco's papers he talks about, you know, child development and how, you know, there's just this constant feedback and interaction between a mother and a child, and it's paying attention to that stuff, and you know, paying attention to the human being, and that you know, if someone is in a room and not making much sense, that if you work really hard to try to translate what the person is saying, or find a way for the person to say something in a way that others understand, and then give that person back that feedback, that has a kind of therapeutic value. So that's just my way of thinking about it. One thing, I think I was reading a paper by Alan Rosen this week, and it was written with parents of a woman who had a lot of problems. And what I took from the paper, Alan, was this idea of hope, and how conveying hope is going to impact a person's trajectory. And well, that's another form of communication, right? It's what you say to someone, and that what you say to someone is going to have an impact on that person's stuff. In my mind, again, I would love to hear what Jaco and Mary say. That's how I've interpreted this. I don't know if that makes sense to you, but.
So, I'm sure you'd all like to join me to thank Sandy and her
marvellous questions. I think it's been such a rich conversation that we've had here this evening. So I want to thank you, and I do want to acknowledge our staff who put time and effort in organising this today as well. So thank you. I'm sure those unanswered questions. Yep. Sandy,